welcome to Five Rivers podcast for this week. My name is Sandeep Misra, and I am the Chief Growth Officer, co-founder at Heald. And I'm super excited today to welcome Erik Schabert to our episode. And Erik, from experience, and I'll let Erik obviously share his background, but Erik is a doctor of osteopathy and is board certified in family practice and NMM. Sorry, that the acronym gets to me, but NMM, and has decades of experience in primary care. Erik, welcome to the show. We're glad to have you join us today.
Thank you very much. Just to expand on that background a little bit, I attended the what is now the Kansas City University of Medicine and Biosciences, their College of Osteopathic Medicine, graduating in 2004. I completed a dual certification residency at what was then Florida Hospital East Orlando, graduating in 2008 with board eligibility in both family medicine and neuromusculoskeletal medicine. NMM is the board certification for specialization in osteopathic manipulative medicine. So my practice was always a split between traditional primary care and manual medicine focused on treating chronic pain without surgery or medicine.
Very cool.
So, yeah.
So I guess besides the fact that we're talking on this podcast, we've got, I guess, two things in common. One, the lack of follicle, I guess, abilities or follicle wealth, and the other is that we were both, had a chance to experience life in Kansas City. I grew up in Kansas City as well, actually, just right outside of Kansas City in Overland Park, and went to school at the University of Kansas, and a huge Chiefs fan. So, hey, that's something in common. We can talk about football and basketball at a later time, but I'm glad that you joined us, and I'm excited that our viewers get to learn a lot from you. So let's dive right in. Erik, you've seen over the last, since you obviously started practicing, and even especially in the last few years, the prevalence of diabetes, pre-diabetes, just continues to be a big problem in the U.S. and now it's actually expanding globally as well. And there's so many different treatments that pop up, so many different advices that pop up, advances in medical care, all that. Yet we are not able to control it. We're not able to reverse the trajectory. We're not able to do much about it outside of just watch what's going on. In your perspective, why is such a big problem? Why are we not able to control it?
Well, I think to start with, we have to dive into the numbers a little bit to really kind of quantify just how massive this issue is. We're talking about, as of 2021, 38.4 million Americans diagnosed with diabetes alone. That's not even pre-diabetes. And that's 11.6% of the adult population. The prevalence is absolutely on the rise, and the rate of increase is accelerating. A 2022 study estimated the annual cost of diabetic care in the United States to be $412.9 billion. So if you're concerned about the cost of health insurance, the cost of general health care in the United States, and the fact that seems to be just flying up, then you have to talk about getting a better handle on the problem of prediabetes and diabetes if we're going to have a real positive impact on it.
Yeah, and do you feel that that patients in this case, or consumers in general, they understand, they kind of know what good control looks like, and if it's even possible, do they have that level of understanding to begin with?
Frequently not, in my experience. They have a very basic level understanding. They know that we have a lot of medications out there to treat diabetes. They're very aware of the use of insulin, for instance, and some other common medications are very much known in the vernacular. Certainly GLP-1 analogs such as Ozempic and Mounjaro are becoming a more and more well-known thing in the U.S. public. Most people are aware of their use for diabetes as well as obesity.
Mhm.
Most people are aware that insulin is used. Now, when you transition from that level of knowledge and the idea that, yeah, if I'm diabetic, I should probably lose weight, that would help. But going from that level to the real details of what needs to be done in order to get a good outcome with diabetes, to reverse the changes that have led to someone developing diabetes, that knowledge really is not there.
Yeah. Yeah, it's interesting you say that, because we've had conversations, at Heald with some of our members that we've worked with over the last few months, or give or take a year. And what is evident, what is I guess I don't know if it's alarming or if it's a good thing. I mean, it's a good thing that they have a control now or handle of it. Is their feedback to us saying, "Man, I didn't know that about diabetes," right?
Right.
And which I'm going, and again, it's not their fault. I don't think we can blame our society for lack of understanding, because again, there's so much information out there. There's so much true, so much false, so much. Everything is politically charged half the time, and there's the pendulum swing of, "Hey man, go this path and do a diet like this, or stop eating everything entirely, take out a complete macro from your diet," and then it swings the other way around and says, "No, no, 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 we were wrong on that side. This is the right side," and then it swings back. So I think there is a sort of a confusion in consumers' mind as well, to say, I don't even know what the hell's true versus what's out there as a conspiracy theory, for that matter. So it's an interesting paradox. It's an interesting challenge that we, from a company perspective, we try to work with. And I'm sure you, as a physician, when you're having a conversation with people too, you're going, "Man, what did you just say? That's not even remotely true. Where did you get that information from?"
Right.
So
Right.
how have you experienced that kind of stuff too?
Oh, absolutely. And I think I haven't been in active clinical practice now for about 5 years, and I think it's gotten worse over those 5 years as I interact with colleagues and discuss this issue, and in some cases we even bounce ideas off of each
Hmm.
other in how to approach communicating with patients to really connect with them. The what we've really seen, I think, since the pandemic is the rise of what a friend of mine called the Ike. He called him the Ike influencer, and Ike being an acronym for "I know everything." Right?
Mm.
These people speak with absolute certainty about, oh, if you just do this, it's going to get everything under control, and
Yeah.
that's never universally controlled or universally true. Excuse me. I think really, for one of the things I try and get across to individuals who are searching for good healthcare advice is, if the person who is giving you that advice is speaking in absolutes because of a generality in the population, not because of characteristics with you. And even then, if they're speaking absolutely, oh, I know this is going to be the case, you probably shouldn't trust them,
Mm.
because real doctors, real physicians who are speaking from medical evidence are going to be hedging their bets a little bit,
Yeah.
because there is a lot we don't 100% know yet. And we can speak about probabilities. We can speak on what is most likely the best thing to do in your situation because of this, this, and this, and this about you. But trying to get up there and say, oh yeah, if you just put Himalayan sea salt in your drink every morning, that's going to solve your diabetes. It's like,
Yeah.
come on, guys.
Yeah. Well, it's interesting you say that, because now that I'm thinking back to my interactions with my physician, right? And anytime we've had conversation about, be it general primary care stuff, or something that is more involved, and something that I'm trying to handle, the usual response is more from to your point, someone who's actually doing this the right way, is to say, "Hey, we've seen, for example, this treatment work in a lot of patients. Let's see if it could work for you, or let's see if we want to try that out in that." It's never been, "Hey, it worked for these 5 patients, i.e., it's going to work for you." And that
Right.
is a dangerous. I mean, to your point, it's a slippery slope, and it's a very dangerous kind of absolute terms to be using to say, no, I know it's going to work. What? No, you don't. You truly don't.
Right. Right. And what we can do is we can look at research like
Yeah.
a good, for instance, and this also I think illustrates a little bit if you want to get into barriers to why we have such problems with control, just with treatments, is traditionally we have gone to insulin very early and pushed going to insulin very early. The problem with that is that using insulin as a primary or sole treatment is going to push up insulin resistance. So you actually have a treatment that, through its mechanism of action and part of what it does, makes it itself less effective over time. And so you get a situation where it becomes more and more difficult as someone ages using that approach for treatment to get good control, because you're going to have more potential to push the blood sugars too low. And one of the things we see is, particularly in individuals as they age, hypoglycemia can actually be worse for outcomes than hyperglycemia. So low blood sugars can be worse than high blood sugars. And insulin, that's also one of its problems. And we've had some recent research that shows even some of our older non-insulin medications, if implemented in combination early, can not only achieve better long-term glycemic control without hypoglycemia than using insulin, but these interventions also seem to reduce insulin resistance over time, and as a result are very helpful. And the only things that we have ever seen reduce insulin resistance over time in treatment of diabetes are weight loss and dietary interventions that reduce simple carbohydrate intake, particularly, but diets that act in such a way to reduce our insulin secretion after meals, and usually those are going to result in weight loss, can result in lowered insulin resistance. And then the other thing is the GLP-1 class of medicines. The entire class, if used in such a way that blood sugars are well controlled, even the older versions of the GLP-1s have shown an ability to reduce insulin resistance over time. And then we have two medications that directly affect insulin resistance, and that is the TZDs, of which pioglitazone is the only one currently on the US market, and metformin, which reduces insulin resistance in the liver directly. Now, pioglitazone and metformin by themselves have never been shown to reduce like overall insulin resistance over time. The GLP-1s have, and SGLT2 drugs such as Jardiance and Farxiga, they do as well, but almost certainly the mechanism there is through weight loss, because they do induce weight loss.
Got it. And again, obviously, metformin is a very common brand. I mean, most people are very familiar with metformin.